Good morning, folks, and welcome to Move Daily Talks. I'm your host, Tracy Steen. And hey, if you're not already subscribed over on our YouTube channel, I encourage you to take a look over there. We have over 2,000 free workouts for you to follow along with: advanced, strength, cardio, beginner, fusion. We've got a little bit of everything and a lot to keep you moving daily. I would also ask, if you're not already subscribed to this podcast, I would love it if you subscribed. You can subscribe again over on YouTube or here, wherever you stream your podcasts. This will help propel this podcast into the algorithm so more people just like you can hear how to move daily in your fitness, wellness, and nutrition for years to come. Today's guest is Dr. Somi Jovaid. She is a board certified OBGYN, a surgeon, and the founder of Her MD, which is a practice she's built, scaled, and then sold after raising significant venture capital as one of fewer than 0.4% of women of color to do so in the US. Her focus is on sexual wellness, midlife health, and the work of closing the gap between what women's healthcare is and what it has always deserved to be. She's one of the medical experts in the documentary The M Factor and 2 New York Times bestsellers, and she hosts her own podcast called The Disrupt Her. I like it. Not disruptor, but disrupt her. So that's awesome. Looking forward to this conversation today. Let's welcome Dr. Somi to the podcast. I'm welcoming Dr. Somi here today, and one of the questions we love to start off with our audience is to ask you what exactly you are on a mission to do. You know, we have a lot of guests who highlight fitness, wellness, nutrition. I just mentioned those things to you. You said that is something I know a little bit about. So we'd love to know, within that field, what are you on a mission to do?
I used to say revolutionize women's healthcare until I realized how broken it was practicing for 2 decades. But now I say to help women become the CEOs of their own healthcare.
I read that. I love that. We say, like in fitness, you want to become the Sherlock Holmes of your own body. So you need to be the person who explores, who figures it out, right? No one's there's gonna be a lot of information out there, people telling you, but you really do have to do your due diligence. So what exactly do you mean by being the CEO of your own healthcare?
I think so many women assume that doctors or providers know better than they do. And that's actually not true. So I want women to be active participants and the decision makers and have bodily autonomy rather than healthcare happening to them. That's when they feel like, or they're passive, participants when a procedure is happening to them, when a menopausal transition is happening to them. That's when they feel like they've been hit by a Mack truck versus when they're informed and educated and empowered and equal partners or even the boss of their own body and their own clinical decision making. It completely flips the script.
I think of my mom's generation, and she's 78, 79. And, all they were told was to listen to the doctor. The
Oh, yeah.
doctor knows best, and that's what you do. You listen to the doctor. I like how things are shifting a little bit now. Although I sometimes think that my doctor must be like, wow, what podcasts and things have you read, studies lately? Because I go in there and I'm just like, I want this test, this test. But it's so great to see our generation now better informed.
Absolutely. And I love it as a provider when patients keep me on my toes and they bring in data or a new treatment option, and sometimes I'll look at it and be like, okay, guys, this is really pseudoscience. It may
Right.
not harm you. Or, oh my God, this is amazing. Thank you so much for bringing this to my attention. Let me look into this further because even though I sit on multiple medical advisory boards, I have published research myself and seen patients for 2 decades. I feel like information is now coming out so fast and so furiously that even the healthcare providers can't keep up. But a really good healthcare provider will listen to you and make it part of the conversation and not do this to you. Like, absolutely, I don't want to hear it. It's like, oh, okay, let's talk about that.
What do you see as being the big issue with the healthcare system? We live in different systems. I'm in Canada here, you're in the
Mhm.
US. So, it would be slightly different, but we also see issues up here, no doubt. So what are you observing as being the biggest issue?
Lack of education, both for providers and for patients, lack of funding, lack of research. Women weren't mandated to be included in clinical research trials until 1993. So we were applying
Crazy.
male, information to women. We are not, I don't know if you know this statistic, but female providers, and this is where sometimes I get a little bit of hate, do have better outcomes with female patients, particularly when you're looking at surgery, cardiovascular outcome, which remains the number one killer of women in the United States, readmission rates. But yet, women providers are only lasting in the healthcare system full time about 6 years before they either go part time or leave medicine altogether. Yeah. So
And
we're
why
not
is that?
healing our healers. Yeah.
Right.
Yeah.
What's the mechanism? Like what's happening there for those women to leave?
So when you look at the data, they say it's lack of mission driven work. Like medicine is not, they're spending time doing paperwork. They are basically the mother penalty.
Right.
They're being passed over for the promotions because they have anticipated time off or they have taken time off. There is still gender pay gap.
Hmm.
So even though we outnumber men in the workforce and tend to have better clinical outcomes in some of the verticals in healthcare, we are not remaining. And then obviously, no matter how kind and helpful our spouses are, there is that higher demand at home to fulfill those other roles, whether it's caretaking for our parents or our children, or whatever it is. So that's pulling women out of healthcare. And so we're losing our healers. So, and then you've got all of this misinformation that we had out there and misinterpretation of the data. And I blame the press and doctors and the establishment equally for that misinformation and truly making women afraid of their own bodies and their own hormones.
Well, what have you done to stay in the game for so long then? Tell us the
Oh
tricks of the
God.
trade.
I say that I, number one, am equal parts teacher and student. So I am forever willing to learn. So I recognize that even though I was a board certified OBGYN, I was falling woefully short with the stories and the problems my patients were coming in with. So I was willing to take the time and spend the money. So on my own dime and time, I say, I learned about menopause, perimenopause, sexual health care, did the preceptorships, and then took my idea to multiple hospital systems. Couldn't find anyone. This was 10 years ago, before the menopause revolution. Cashed in my 401k and my life savings, bought a building, started a practice that was provider and patient centric. Longer appointment times, specialized in advanced gynecology, menopause, and sexual health care, so that the type of medicine that I dreamed of practicing I could actually practice with superior outcomes. And then I went one step further as women were coming from all over the country and other countries, is I set up an academic platform so that the results would be initially just at all the HerMD locations. Now it's out in the ethos, helping other providers deliver care for patients who need this type of healthcare.
That's fabulous. You said, patients are coming in with dominant problems. What are some of the dominant problems you're seeing in our age group? So I'm talking 45 to 65. What are you seeing these days?
Loss of sex drive, insomnia, brain fog, mood swings, fatigue, painful sex, and really women saying, I just don't, weight gain, joint pain, frozen shoulder. But the bottom line is, I don't recognize who's looking back at me. I don't recognize the things that are coming out of my mouth. Like I am telling myself, don't say that. You don't mean that. And I either fly off the handle or I'm crying. So I
Hmm.
don't recognize myself emotionally. I don't recognize myself physically. Or Dr. Javaid, I'm doing all the things nutritionally, sleep wise, exercise wise, and my body is changing and the numbers on the scale keep getting larger. And so that is repeatedly the three themes that I hear in this phase of our life.
Mhm. And there's so much to unpack there, isn't there? It's like it's not
Mhm.
just, okay, here's a prescription, here's a simple solution. How do you begin to unpack that with your patients?
It's the biopsychosocial approach. So, really, you have to take into account all of their thorough history. What are your other medical problems? Have you had a workup before? What medications are you on? When did your symptoms begin? How are they related to your cycles? So, a thorough history. And you have to take into account biology, which is the hormones, psychology, the way people are feeling, and their beliefs about things.
Mhm.
Because I might think, a treatment option is a great idea, but if they don't believe in it or they're afraid of it, it's not going to work. And then
Mm.
the social, what is going on? Are they all of a sudden caretaker to their parents? Did they just lose their job? Are they struggling in their marriage? And so, really understanding all of those and then coming up with a curated plan of treatment and then asking them what is bothering them the most.
Yeah.
And then, meeting them where they are and what are you willing to try and what are you afraid of? And you'd be amazed when you give women the time and the space with those questions, how much they're willing to share, even though it's so deeply personal.
Mhm. We just want people to know our story, don't we?
Hmm.
Mhm.
Yes, I love storytelling.
Well, I
Combined
think
with
it,
data. I mean, that's
yeah.
what helped me raise $40 million was, you can give people facts and figures, but when you can tell them an incredulous story and back that up with data, it's amazing how many people you can get to lock on to that. Yeah, to
Yeah.
that story.
Mhm. One of your main focuses is on sexual health. How did that arise for you as being something that is one of your dominant focuses?
Patience, and
Their
listening to
need.
their need, and then feeling like a complete failure. Here I was, a board certified OBGYN who was listening to countless stories of either cancer survivors or women in perimenopause or menopause, or just because having low libido, having painful sex, not being satisfied, or having check a box sex, or having problems with orgasm and or lubrication. And I realized in my training that my sexual health definition was contraception, fertility, and treating infection. And I knew all about the male options for ED as a board certified, OBGYN, but I couldn't address the domains of sexuality, is what we call them. And there's a gold standard test that women can take at home called the FSFI. It's 19 questions. And it looks at those domains of sexuality, the libido, the orgasm, the arousal, the satisfaction, the lubrication, the pain, and tells you, it gives you objective data. Because people say sex is hard to measure. And so really wanting to meet the needs of these women who were so brave and talking to me about some of the most private, intimate parts of their life, looking for help and not being able to offer them solutions drove me mad. So went and we did a preceptorship, learned, got additional training, and then really wanted to hone in for these patients.
Mhm. I'll link that in the show notes, the FSFI test for those who are interested. So you can take a
Yeah.
look in the show notes below. Let's dive into sexual health a little bit more. We hear a lot of people our age are going on testosterone
Mhm.
therapy. I have heard that a lot of people go on, or it's been prescribed for things other than libido. And
Mhm.
so I see in social media there's like a conversation or a debate rather of what testosterone really is good for. And I'd love to hear your thoughts and opinions on that. Who is it for? Who does it work for? Who should it be prescribed for? Let's dive into this one.
Yeah, so testosterone is, if you want to ever get providers into a heated topic, man, just bring up testosterone for women.
Right? Like this is what I'm saying. These
This
influence doctors, it's like, ah.
It's a hot button topic. My patient a couple months ago was literally told, she asked her doctor for testosterone, and he said, "Why do you want a male hormone?" And she was like, "Well, my ovaries produce testosterone. I know that I make it. I know that it's measurable." And I love the fact that she stood up for herself. She still ended up with me so that she could get some treatment. So there's a global consensus statement and a menopause society statement, and you have to look at guidelines, and then you also have to say, okay, there's guidelines, which usually kind of lag behind, and then there's also, the data, and then there's data emerging all the time. So the guidelines, there's a global consensus statement saying that testosterone should be used for low libido or hypoactive sexual desire disorder, HSDD, in menopausal women. And Menopause Society says something very similar. It actually recommends checking levels and making sure that we are getting women only to physiologic levels, not supra physiologic levels, so we don't give them problems like abnormal hair growth, acne, hair loss on the scalp, clitoromegaly or the clitoris growing if it's really high, and then vocal cord thickening. There was actually a pretty powerful piece in the New York Times talking about unregulated testosterone and all the things that can happen in the wrong hands or the wrong dosages. That being said, I am a huge proponent of testosterone. It helps actually with all the, if you look at the data, with all the domains of sexuality, with orgasm, with arousal, with desire. There is also data to say that it supports muscle mass. It makes sense. And therefore, bone density helps with mood. And there is some data that adequate serum levels do also reduce our risk of dementia. And we know that dementia disproportionately affects women. That is who it's for. So I would say the perimenopausal patient who may either be symptomatic or who has low levels, because I describe perimenopause and menopause as the visible symptoms that impact your quality of life, fatigue, low libido, hot flashes, insomnia, but also the invisible symptoms, the brain changes that we see that can later lead to dementia. We actually start to see that on brain imaging in midlife. Cardiovascular changes that start to occur that increase our risk of heart attack and start to occur in midlife and with the loss of estrogen. And then loss of bone density happens in perimenopause, actually even before menopause occurs. And so if we can intervene earlier with estrogen and testosterone and progesterone if people need it, we can actually not only live longer, but stronger and healthier.
Yeah, interesting. A lot of, I can't remember her last name now. It's Dr. Susan. Do you know who I'm talking about? Dr. Susan, who is, I'll look it up and post it on the screen, folks. But she studied testosterone for years and years over in Australia. She's done for the past 20 years all her trials. She's a researcher, scientist on testosterone. And I know one of the things that she speaks about is that testosterone is great for libido. And then
Mhm.
all of the studies do show that. You mentioned some other benefits, muscle, brain, but she is, according to the research she's looking at, still a little bit leery on saying that we're going to take it for those things
Mhm.
specifically. Byproduct, maybe, yeah,
Mhm.
it's possible
Yeah.
that you have these benefits. So I'd love to hear your opinions and your thoughts on fine tuning that a little bit. Is it something that if we do have sexual dysfunction, low libido, and we're like, okay, I'm struggling with this, I'm going to go on some testosterone therapy and get some additional benefits possibly, but for sure, I'm going to, it'll be beneficial for my libido. Or do you have people coming in saying, okay, I want to protect my brain health, my muscle mass, put me on testosterone? Yeah, I just love some
Right now,
clarity.
it's mostly for sexual function, sexual issues, problems that people are actually coming in asking for testosterone.
Yeah.
There are also women who you check their testosterone level and it's undetectable and they just don't feel like themselves. And let's say you have put them on estrogen or estrogen plus progesterone if they so desire and have a uterus, and they're still not feeling great, meaning they're either struggling with their sexual function or they're tired or they're still saying that their body composition isn't changing with all the nutritional and exercise that you have, changes that you have recommended. I will give people testosterone to see if I get them to physiologic levels, meaning we check their labs.
Mhm.
Um, is that the final puzzle piece? And
Right.
for some patients, it's not.
Yeah.
And some patients will come in with an undetectable testosterone and their sex drive is fine. But sex drive is not just solely driven by testosterone, right? That's why I talked about the biopsychosocial approach.
Sure.
Are you stressed? Do you like your partner? Are all your other neurotransmitters that are involved in arousal and orgasm, are they working? Are there
Mhm.
problems with brain and spinal cord? Are there skin lesions that may be negatively impacting your ability to feel good sensation? Are you having pain?
Mhm.
If you have pain, your libido is going to be down regulated because who is going to be driven to do something that hurts? No
Sure.
one.
Right.
So I think it's very nuanced. I think it's individualized. And I think you are right. We do need more data. You cannot say that testosterone has an indication for cognition or mood, but you can certainly say in my clinical experience, when I have put patients on who have been struggling, I have seen improvement.
hmm This is why I love, your thorough intake because all of the parts inform your decision as a clinician to prescribe or not. And I
Mhm.
think that's so important for us listening that there are a lot of variables that we
Mhm.
need to be telling our physician in order to get the proper response. I saw this post on Instagram, and then someone duetted it or did a response. But the comment on the post was this woman walking kind of proudly, saying, "Thank God I haven't gotten caught up in the MLM of women's hormone therapy." And then it's just like, what? But she was very proud as punch that she's not taking hormone therapy, and she's like kind of priding herself in that. I thought that was hilarious, but because it's so stupid. But this other doctor duetted her and said, that is so stupid. Why do you see this? Are some women like, I'm not taking hormone therapy, I'm better than others because I don't have to take it versus, like, what are you seeing in that realm?
I am seeing some of this, not a ton, because a lot of those that seek me out do want to have a very robust
Sure.
discussion.
Yeah.
A lot of them are still coming from a fear of hormones from the WHI and, frankly, from the press statement that came out
Yeah.
about the overstated claims. And but there are some people, just like when I saw in obstetrics, women who wanted labor without any drugs.
Right,
I'm not going
right.
to call it natural. Or I don't want to get into that debate because I did this beautiful project with Peanut called the Renaming Revolution, taking out harmful language, and worked with a
Oh,
linguist and a psychologist. And for me, it was so empowering to do this for women, but it was also learning and humbling, saying, oh my God, couldn't even imagine that that would be
yeah.
harmful for a patient to hear that. So I don't want to say natural, but I'll say, labor without drugs or intervention was very important for some women. And it was a badge of honor versus those who, had an epidural or a spinal or needed some type of mitigation of pain.
Mm.
I see that with hormones. Like, why would you replace it? Our body is naturally, lowering its levels. It's happening for a reason. And my response usually is, well, life expectancy wasn't what it was,
Hmm.
like it is now. We were previously not outliving our ovaries. And if we know, even if you're not symptomatic, this is where I get into the invisible symptoms, that there are changes going on in your brain that are going to increase your risk of dementia. And we are, beginning to understand that through Lisa Mosconi's research of the estrogen receptors and how we don't optimize
Mhm.
glucose anymore in our brains. Therefore, we start to use our own brains as Kelly Casperson said this on social media, and I love her, but
Mhm.
people were like, oh my God, your brain
Oh,
starts
yeah.
eating
I
itself. It's
know
like,
that was
well, it
crazy.
starts to use it as fuel. So you do start to see atrophy, and you do not see that age match with men. So we're learning all of this. You start to see cardiovascular changes, and our risk starts to match that of our male counterparts. And we start to see osteoporotic changes or even osteopenia, and we're not screening until 65. So my discussion with women is, well, that's fine. Help me understand, is it coming from fear? Is it coming from, you think it's going to cause cancer, or that you see no benefit if you're not symptomatic? Because let me tell you, there is benefit, and then break that down for them. And if
Mhm.
they still don't want hormone, I'm all about bodily autonomy. It's your body, it's your choice. My only thing is, my bottom line statement is please make decisions based on the data of today, not the myth of yesterday. Like that bottom line, if I could describe it in one. But yes, there are women that think it is unnatural to replace hormones, even if we are using bioidentical transdermal, hormones. They are still very against the idea. And I have some really good girlfriends who are very anti-hormone. They just believe in doing things through nutrition and exercise and really good sleep hygiene and meditation. And I respect that.
Mhm. It is interesting for me. I'm 56. Menopause was about 3 years ago, and I'm not on hormone therapy, but there's a few reasons, and I get asked this a lot, so I'll just explain to the audience here that I had my DEXA scan a number of years ago too, and I've had multiple since. So I've got really great bone density, good T score, Z score. So I know that hormone therapy is indicated for the prevention of osteoporosis. So fantastic. If I was osteopenic or osteoporotic, definitely I'd be like, okay, I need help. Obviously, I do have aura migraines, so I've read a little bit about that possibly being contraindicated for additional hormone therapy. And then I don't have vasomotor symptoms, so I'm feeling pretty good through menopause. Like I don't have a lot. So this is my question. I'm in this space where I feel like physiologically and psychologically, mentally, I don't need it, but I'm constantly being open to listening to research that could say it's, protective for your brain, for dementia, for bones, for heart. And so it's a tricky place to be because you don't want to miss out, but
Mhm.
I also want to consider everything. So yeah, it's an interesting time.
Well, I don't know if you know this about me, but I struggle with migraines with verbal aura and actually had a very prolific public event where people who were watching thought that I had a stroke.
Oh dear.
And I ended up going, and I, in my residency, learned that, women with migraines with auras, you traditionally did not put them on birth control or contraception because you increase their risk of stroke.
Right.
I had a very eye-opening conversation with my neurologist at the Gardner Institute in University of Cincinnati because once they ruled out tumor, stroke, ALS, MS, like I went through the whole thing. They thought that perimenopause and the hormonal fluctuations were the reason. And so they actually had data that is newer in neurology, and they recommended hormone therapy.
Mm.
And it actually, along with some other medications, has really stabilized my verbal auras, like to the point where I am publicly speaking again. But
Mm.
I went through 6 months of speech therapy after my initial incident when they were working me up. So the data is slightly different with hormone therapy versus birth control, and it's kind of coming full circle. And I joked with the professor researcher who told me this. I said, he goes, well, it's well known in the neurologic data. And I said, why aren't you sharing this with the menopause experts? Because I said, this is the first time as a patient that I'm sitting here learning that my patients with aura actually may be candidates. So it was very, very interesting.
Mm.
And I would tell you there was a paper that was just presented at Menopause Society October of last year, showing a 60% reduction in the risk of cardiovascular disease, stroke, and breast cancer when hormones are, if we had a magic wand, it could start them 2 years before the anticipated date of menopause.
Mhm.
So there's more and more data coming out about the protective benefits of hormone therapy, particularly with transdermals, because, going through the skin, you avoid the liver where all of our clotting factors are made. And so you don't have that same risk of heart attack and stroke like we saw with the oral formulations.
Okay. Hmm.
Yeah.
What is verbal aura?
Verbal aura. So, I actually, my speech became garbled. And there's actually a very famous clip of a news reporter who got accused of, they thought that she was drunk.
Oh
So she
dear.
was speaking and
Yeah.
then it became very garbled. And then I lost my speech altogether.
Wow, that's
Yeah.
scary. Yeah, I have Aura no pain, but it's still super annoying and flashy, but
So you
it
have
has
visual auras, and some people
visual.
have sensory auras, like
Yeah.
where parts of their body go numb or tingling.
Yeah.
So yeah, yeah.
But
So
it did scare me, thinking that there's an increase of stroke risk, and then hormone therapy. I know it's super, super minimal, but when you read all the risks, that is a very minimal risk as well. So you're sort of weighing the pros and cons, right? But you don't want to miss out. And I feel like a lot of our audience who are listening, are in the same boat. They are hearing more information. You don't want to miss out and look back and say, oh, darn, just like what you said about the perimenopause. Like if you could have waved a magic wand and started, a couple years before you knew menopause was coming, but we don't have that, but we are learning more. So I guess that's super. But yeah,
And I
it's
think the one distinction we should make too is localized hormone therapy, right? There's very, very, very minimal systemic absorption. It's really just localized. And for that, it's not only for women who are sexually active or intimate, it also prevents our risk of urinary tract infection, vaginal infections, hospitalizations, exposure to antibiotics. So most women, I mean, Dr. Malone will say all women are candidates for localized hormone therapy, with the exceptions of, people who have active vaginal lesions or unexplained vaginal bleeding or are in the midst of, maybe active cancer treatments. There are very few exceptions to women who are candidates for localized hormone therapy, particularly not only for treatment quality of life, but also for prevention of urinary tract infection.
Mhm. Could you differentiate between those two just for our audience? What is considered systemic
Yeah.
hormones and then localized, which everyone safely can be on?
Yeah, so systemic means, well, number one, you're taking it for the head to toe symptoms that we're talking about, hot flashes, right? Weight gain, mood swings. Localized is either a cream, a ring, a suppository, and it might be an estrogen or it might be a DHEA product like Intrarosa is the trade name. They are used anywhere from nightly to, just twice a week, but really minimal absorption. You can't say zero because the vagina is another orifice where you can deliver medication. But basically, if you were to check your blood levels at the time you start and, a couple weeks after you're on it, you usually will see zero change in the serum levels of your estradiol when you deliver these medications. So those medications are not meant to treat the head to toe symptoms, will not protect your bone, brain, or heart, or
Mhm.
can be used for the prevention of osteoporosis. Those are literally to treat something we call genitourinary syndrome of menopause, which is,
Right.
the umbrella term, right, for the bladder and vaginal symptoms we get from loss of collagen, elastin, blood flow, decrease in the acidity of the vaginal environment or the microbiome from the drop in our hormone levels. And then also the loss of the rugae or the folds. A healthy vagina is deeply pink or deeply colored, has these deep folds like an accordion. And when we look at a postmenopausal or menopausal vagina, you can see that there's a flattening of the folds, which can, then tear during intercourse and be painful and itchy and then dry. But the color also changes and the tissue becomes pale as we lose blood flow. So those localized hormones are used for just that collection of symptoms.
Mhm. Do you put every patient, except for those with some of those contraindications that you talked about, do you recommend that for everyone?
I do
Mhm.
because I know that women die from complicated urinary tract infections.
Yeah.
They die from urosepsis, that we're spending millions, I think almost billions of dollars in unnecessary ER visits and hospitalizations. And so, yes, I'm a believer that almost every woman should be on a vaginal estrogen or vaginal hormone product, even if they aren't sexually active, to prevent urinary tract infection or complicated urinary tract infections.
Sure. Excellent. And what's that? What if we're going to our doctors and asking for it, what do we ask for?
Vaginal hormone therapy.
Yeah.
Yeah.
Okay. Simple as
Because I
that.
don't want to I want everyone to get whatever's covers best. I don't want them to pay $160 for,
Sure.
Intra Rosa if they can get, vaginal estrogen cream for $6.
Okay.
So, work
Doesn't
with
have to
your
be.
provider.
Yeah.
Hmm.
Doesn't have to be expensive. Excellent. Um, another um, topic, I suppose, that's getting a lot of eyes right now are peptides. And I'm wondering what you're hearing in that space and if your patients are coming in and asking for that. I've listened to a few podcasts so far. I'm on a learning curve right now to try and figure out exactly what they are, what it means. And we did just see some get FDA approved. So what are your thoughts on that?
I'm still also on a big learning curve with that. It's not something I was trained about. Definitely have patients asking about it. I'm starting to read about them. I know there's pros, I know there's cons. I think for me, what scares me is the lack of regulation, how many are entering the market, the claims. And so for me, when someone uh, asks me for a recommendation, it means that I can talk to them thoroughly about risks, benefits, alternatives. And I'm not quite there yet. And I'm not sure if the data is quite there yet. So I know there are big believers. And if a patient really, really wants peptides, then I will send them to someone who is much more well versed than I am. I'm interested. I'm intrigued. I will tell you that.
Mhm.
But I'm not quite ready to say yay or nay on peptides until I fully understand them.
I hear you. I'm intrigued as well. Like I feel when you hear some of the things that are happening to people, and of course, yes, a lot of them are being guinea pigs and, taking one for the team to figure out how these peptides work on humans. But sometimes you think, oh, that'd be nice not to have to work so hard to get those results and just take a shot, take a pill, take a whatever. You know what I mean?
No, for sure. Yes, I know.
Yeah, so I'll look forward to hearing more about this in the years to come. I'm sure there's a lot more study to be had on all of that for sure. Anything else you'd like to tell our audience about how to improve their own experience in the healthcare system?
No, for sure. I think the one thing we didn't cover is that, there are two FDA approved medications for women who are struggling with low sex drive, particularly those women who maybe are not yet ready and they're digesting the testosterone information. There are two non hormonal FDA approved insurance covered medications that work on neurotransmitters in the brain. They're only indicated right now to help with low libido, but for those women I have witnessed lose relationships, lose self-confidence, lose their marriages because they have no sex drive and their partner assumes and takes it very personally because they
Sure.
don't understand or aren't given the vocabulary. So Addie is a nightly medication, works on neurotransmitters, was FDA approved 10 years ago. It's not an on demand. The press called it female Viagra. You take it every night, regardless of whether or not you intend on being intimate. And it showed three clinical endpoints. It increased desire for women, decreased the distress associated with your sex drive not being where you want it to be or where it once was, and increased number of sexually satisfying events, meaning eradicating that checking a box sex or, oh my God, one more thing I have to do. And the other one is Vyleesi, and that one is more similar to Viagra in that you inject yourself 45 minutes before you want to have sex. The effect lasts about 14 to 16 hours. And once again, both are non hormonal and indicated for low sex drive. So, yes, men do have over 20 optionalities for sexual health, but women do have two FDA approved options. And the reason I'm saying this is less than 5% of providers know about these, and less
Oh,
than 1% of the general population knows about them. And so,
wow.
yeah. And so sexual health for me, for what I do, is yet another vital sign when I'm talking to a patient. And listen, if you're like, that part of my life is over, I'm done, I'm happy, I'm not chasing you with medications or options. I'm talking to the women who are like, what happened to me? I love my partner, but I could care less about
Yeah.
sex, Dr.
Yeah.
Jovaid.
Yeah.
Those are the, patients that I'm speaking to and saying, hey, you don't have to give up. There are options.
Can you talk about any side effects from those FDA approved ones from Addie?
Yeah.
Yeah.
So Addie actually was initially studied as a mood drug. So it actually helps with anxiety and depression. It does not cause weight gain. It causes profound sleepiness. And so it
Oh
is
dear.
literally, and no, in a good way, though. It is a nightstand medication. So you have to take it at night. It
Right.
cannot be mixed with alcohol. So meaning it's the rule of twos. If you've had more than two drinks, you skip it. And it should be taken at least 2 hours from your last drink. It's kind of like you wouldn't take Ambien or a sleep aid or Xanax along with alcohol because somnolence or sleepiness is the number one side effect. Vyleesi, about 30% of women will, that's the injectable. And I love to laugh with my patients. I think laughter is the best medicine. They'll tell me all about their Botox to their face, and they'll tell me about their GLP-1s to lose weight. And then I'll tell them about an injection for sex, and they're like, "What? You want me to inject myself?" And so I'm like, yes,
Yeah.
it's a really tiny, needle.
Yeah.
But you can't are not a candidate for it if you have uncontrolled high blood pressure because it can increase the blood pressure. And it can cause nausea in about 30% of patients. So my patients who braved it out because they liked the return to libido and they liked like timing it said that with each subsequent injection. So what I have observed clinically is that the nausea gets better. Kind of like, a lot of women will have nausea with birth control when they first start, and then once they get used to it. So they say that the nausea improves with each subsequent injection.
Well, what's the mechanism? Okay, so if it makes you sleepy, obviously it still arouses you before you get sleepy. So is it an increase in blood flow or how does
No,
it
it
work?
works on the neurotransmitters that support sexual
Dopamine?
function, dopamine, yes, norepinephrine, yeah. So that's how it works.
Okay.
And
Would
so
would there be some contraindications if you were on a GLP-1, which dampens dopamine, and then you took this and it heightens dopamine? How does that all?
no,
Okay.
there's no contraindication. There are certain medications that you would have to be careful with because everything's metabolized through the liver and your doctor, but no different than any other medication. When you put someone on a medication that's metabolized through the liver, so there are medications like you have to hold your Addy if you're taking diflucan. Like so, but this is not atypical. But what was atypical is the amount of attention Addie got for, well, you can't take this one and you can't do this and you can't drink. And it's like, well, there's a lot of medications you can't do that kind of
Sure.
stuff for.
Yeah.
I think it's because it was the first ever female sexual healthcare drug that it got unique scrutiny. There's a great documentary out there called the Pink Pill documentary talking
Mhm.
about the battle to get this drug FDA approved and just the controversy initially that surrounded this medication. But then what I love is because I have published papers on this medication, is the lives that it did change. And it's not for everyone, but it can be an option for a lot of patients.
Mhm.
And I've seen a lot of success when it's done correctly in that biopsychosocial model of delivery.
Mhm. You have a few books. Can you tell us what your books are about?
So I am writing my book, and it is all about my journey to my mother, who nearly died at the age of 45 to cardiovascular disease, and how I thought becoming a doctor was going to revolutionize the system, and then cashing in my 401k and my life savings and opening a building, and then scaling and raising 40 million and founding her MD and combining all of my own personal health care. I went through infertility. I delivered a baby while I was in labor because my male partners would not come in and relieve me. So
Wow.
basically, healthcare from my vantage point and my patients' vantage points, and everything that I have done to try to make it better. And then highlighting those stories and then combining them with almost a toolkit for patients with different sexual function and hormonal issues. And so, kind of that way everyone, they may not have the language and understand what dyspareunia is, but you know what sexual pain is. But if you hear that at the doctor, you'll remember the story I told along with all of the options that you have. And I like to combine medication, therapy, radio frequency, procedures and femtech and innovation and direct to consumer. I like to help people and meet them where they are in their journey and give them all of their options.
And what's that called?
I Can Do It With a Broken Heart is the working title right now, because of how hard it was to raise capital and to honestly do anything in the women's healthcare space without shame and stigma and taboo and just so many barriers. I was given less than a 0.4% chance of successfully fundraising as a minority woman in healthcare. Yeah.
Yeah, that's incredible. Well, thank you for being a pioneer in this field for all women behind you. I think that's fantastic. You've done so much to help our women. So blessings to you.
Oh, thank you.
Thanks for being my guest today. Now to all of you, go move daily in your fitness, your wellness, nutrition. You'll be able to find all of the information that we talked about here today in the show notes below. And you can follow Dr. Somi. What's your handle over on Instagram?
Somi Jovaid, MD,
Okay,
on
perfect.
Instagram, and my podcast is The Disruptor.
Yes, I loved that title. I thought that was so clever. Disrupt Her. And you can listen to that anywhere you stream your podcast. Again, all of those things will be in the show notes below. All right. Thanks a lot, folks. And we'll see you all in the next Move Daily Talks.